So welcome, everyone. My name is Paul F. Austin. I'm the founder of Third Wave and the Psychedelic Coaching Institute. And today we're diving into a conversation that's urgently needed. How does microdosing and general psychedelic use compare to SSRIs for treating depression? The thing is, we're seeing a mental health crisis. Over 21 million U.S. adults are depressed or on antidepressants. And just a few weeks ago, we hosted a deep dive conversation with Dr. Rabin Carhart-Harris, one of the world's leading psychedelic researchers and neuroscientist. And Rabin led the first modern clinical trial comparing psilocybin to SSRIs head-to-head, and the results were compelling. While SSRIs tended to blunt emotional responsiveness, psilocybin appeared to reset the system, rebooting emotional patterns, enhancing neuroplasticity, and creating space for psychological insight. But that trial focused on high doses. And in the real world, we're seeing millions of people who are microdosing psychedelics, especially psilocybin, seeking those same benefits, but without the intensity of a full trip. And so the question we're exploring today is, can microdosing offer a new path forward for depression, especially where antidepressants fall short? And to explore that, I'm joined by Dr. Dave Rabin, board-certified psychiatrist, neuroscientist, and co-founder of Apollo Neuro. Dave has helped thousands of patients navigate depression, trauma, and nervous system dysregulation using an integrative approach. He brings both clinical wisdom and scientific rigor to the frontier of mental health, and I couldn't be more excited for this conversation. So let's give it up for Dave. If you could give a virtual round of applause. And Dave, it's great to have you.
Welcome. It's good to be here. Welcome. Thank you. And always enjoy. Thank you. Always enjoy this opportunity to share all the learnings that we have really achieved in neuroscience over the last couple decades that are not well taught. So thanks for having me.
All right, let's just start with SSRIs. I want to start with, what is the serotonin sort of hypothesis, if you will, and why is it that SSRIs have become the standard treatment of care for the last 40 years in the West?
So I think the best way to start out with is what are SSRIs? Because SSRI stands for selective serotonin reuptake inhibitor. And these medicines literally inhibit the reuptake of serotonin by the cell that releases it. And so when serotonin is in the synapse, it increases activation of the receptor. And when it gets uptake by the cell, it decreases in the synapse, and the cell reclaims serotonin to do another burst release the next time you have an experience, right? And so selective serotonin reuptake inhibitors just increase the amount of serotonin molecules that are in the synapse where the message gets communicated to activate serotonin pathways. This was one of the first discoveries of SSRIs that actually I think stems back to heavily contributed to by the Albert Hofmann's discovery of LSD that helped us to understand how the serotonin system works so that we could even come up with an SSRI. But the point being that those were developed as one of the first medications that targeted a single receptor site, the serotonin receptor, of which there are many. This is particularly the one that's interesting in the psychedelic conversation, is predominantly 5-HT2A and 5-HT1A, which are two of over a dozen serotonin receptors that we know of. But they thought that because you could change the serotonin balance in the body with one drug and start to help stabilize people with very severe depression, that it meant that if you had depression, you have a serotonin imbalance in your brain. So that's the slippery slope of science, what we would call scientific misinterpretation, because just because A leads to B does not mean that B leads to C. It means that A leads to B, and A leads to B means in this case that if you augment the amount of serotonin in the synapse, that you can stabilize people with severe depression and fairly reliably stabilize them within 4 to 12 weeks, which at that time in the 80s and 90s when these drugs were developed was like pretty great. And you can't, if you overdose on them, you typically don't die from overdosing an SSRI. So it can be used with suicidal patients, actively suicidal patients. And so that's why these drugs exist, and they're used to stabilize. But by nature of them stabilizing, they numb us to emotion, not just negative emotion on the bottom end of the spectrum, but also to positive emotion. They shrink what's called the emotional window of awareness. And so that's how they stabilize you, is by shrinking the emotional window of awareness. Are you still with me, or did I lag too much?
I'm still with you.
So that's kind of, I just wanted to make sure people understand, like, that's kind of how SSRIs are working. And they have a very important purpose, which is to stabilize people with very severe depression and intense anxiety episodes, where other drugs would be more harmful to administer in those situations, or not as effective. And they work for that. But they don't work well for people who have, like, generally speaking, like mild to moderate depression, who have to end up taking them for many, many, many decades, or end up just taking them for many decades. It doesn't often work well for many of those people to achieve that stabilization effect. And then the question is, well, what happens? What do you do after you stabilize somebody? Right. And then that's where we get into the interesting opportunity for psychedelic medicines to help in a lot of ways transition people off of lifelong SSRI therapy, so they don't have to take it and risk getting the side effects for, the side effects of SSRIs, which increase as you take them for longer. And so then you can use psychedelics as an opportunity to safely transition people off of SSRI and other antidepressants that are more harmful into, what is eventually like a drug-free, self-regulated life.
So this notion of, the serotonin hypothesis, that if we have an impact on serotonin, that depression is a chemical imbalance in the brain. I think the first book that I read that really nuked this theory in my mind was called Anatomy of an Epidemic by Robert Whitaker, which went into detail about the overprescription of not only SSRI medications, but also ADHD medications. And that these drugs are prescribed as young as 3 years old, 4 years old, sometimes, which, as you can imagine, is likely harmful for development. So my next question is going to be then, when we look at psychedelics, and I also want to make something very clear, that there will be some speculation today, and probably most of that speculation may come from me. There may be some from Dave's part as well, in terms of what he's seen when working with clients and folks like that. A lot of the clinical research that we have about microdosing is still early, and yet, Dave, I have to ask you, if SSRIs help to, let's say, keep more serotonin in the synapse, or generate more serotonin in the synapse, what is it that these 5-HT2A substances, sort of agonists like psychedelics, do? What is it that psilocybin is doing to serotonin? And what are the potential risks or complications with combining then SSRI use with things like psilocybin and LSD and some of these classic psychedelics?
Sure. Yeah, I can get into that. I think I'll talk about the second part first, because that's easy one to cover. And I think that's really, really important to mention, is that we do not recommend combining SSRI antidepressants, or for that matter, any antidepressants, including tricyclic and MAOI antidepressants, with psychedelics that are activating of the serotonin receptor, which are basically nearly everything that we talk about here, except for cannabis and ketamine, is not recommended to be used when you're taking SSRIs. And the reason is because SSRI antidepressants, as I said earlier, work by decreasing the reuptake from the serotonin receptor, or sorry, from the synaptic cleft where the serotonin gets released. There's uptake is inhibited, so it's not, the serotonin that gets released is not going back into the cell as quickly. And when you take a psychedelic, it increases burst release of serotonin on one end. With certain like MDMA, for instance, MDMA-like molecules increase burst release of serotonin from the presynaptic neuron. Then they bind to the active site of serotonin receptors. So they actually sit in the same location on the receptor that serotonin sits, and increases activation instead of serotonin does its own increase of activation. And so it's a like partial competition for serotonin, but still boosting effect at the receptor. And then the third thing that it does that was discovered relatively recently in the last 10 years that is fascinating by Franz Vollenweider's lab is that, and others working with him, that LSD and psilocybin, particularly LSD, bind to the side of the serotonin receptor, which is and 5-HT2A receptor, which is called a allosteric site. And when they bind to that site, the receptor changes its shape and then clamps onto serotonin more tightly. So it's still, the receptor is now, the cleft is filling with serotonin from the SSRI, preventing its reuptake. Then you get burst activation, more activation at the receptor site, and LSD, psilocybin binding to the receptor and increasing the way that it binds tightly to serotonin and for longer. So you get longer increased activation of these receptors, plus more serotonin, no breaks, that can start a chain reaction in the serotonin receptor where it gets overactivated to the point of causing serotonin syndrome. And so that's the biggest risk of combining these together, which is you can die and you have to go to the ER if you start having symptoms of serotonin syndrome. So it's like actually bad, and it can happen at low doses of SSRI and low doses of psychedelics. So we recommend not mixing the MDMA family, phenethylamines or tryptamines, with SSRIs on board. So your choices are then to taper off of your SSRI on your own or with a doctor's guidance, which I recommend with a doctor's guidance, which would take usually 4 to 12 weeks, depending on you or your patients. And then, or to accelerate that, you can use ketamine. And so ketamine is compatible with SSRI and other antidepressant molecules, and it's also compatible with lithium when lithium is being used as a like gentle mood stabilizer in certain patients with like bipolar 2. We don't recommend using psychedelics with bipolar 1 patients or with psychotic patients or people who have personality disorder, which can be hard to identify. So we do not recommend using psychedelic medicines with those folks because they're at extremely high risk for exacerbation of symptoms if they're not managed very carefully by a trained psychiatrist. But you can use ketamine for most people to within 3 to 6 doses over the course of as fast as 3 weeks, as long as 6 weeks. You can accelerate somebody's taper off of SSRIs, and then you can transition them into a microdosing protocol with, which is Paul Stamets' recommendation, where you complete a macrodose experience, for instance, with ketamine, and then you've unlocked 3 days of 72 hours of neuroplasticity, right? Like after the ketamine, after any powerful macrodose experience, you've unlocked a critical period where neuroplasticity, the normal neuroplastic learning processes in our brains, are accelerated in their ability to form new connections and break old unuseful connections. And so if you amplify that neuroplasticity with ketamine to get 72 hours of experience of neuroplastic window, then critical period, then you have your integration therapy, ideally, right after, and then on a continuous basis, and you can start a microdosing protocol if you're a good candidate for one after the macrodose experience to really jumpstart the recovery, healing, learning process. Does that make sense?
It makes sense. And I want to go further in because I think this is like an essential point that we really need to cover in detail. And I'm going to provide a little more context here so folks are aware. So this, what Dave has communicated about, do we know microdosing of psilocybin while on SSRIs? came as, I would say, news or a surprise to me about a year ago, because prior to that, there were folks like, Jim Fadiman has said publicly, okay, it's safe to take SSRIs with microdoses. And look, Jim's a psychologist, right? He's not a psychiatrist. He's not a neuroscientist. He's a psychologist. And this is just from his citizen science reports. We've seen, from the Lichty lab, the clinical research has come out. I believe this was paid for by Compass Pathways, where they said it is safe to take psilocybin while on an SSRI. And obviously this is a really important conversation, because if you can treat people on SSRIs with psilocybin, your total addressable market is much bigger, rather than having to taper them off for many weeks before you can actually start to use psilocybin. So there is a financial incentive. And I also know that, I know there are folks here who train practitioners or provide underground psilocybin. And there's a lot of people who have gotten off SSRIs while actively microdosing psilocybin have had no problems. And so I'm curious, just to go a little bit deeper into this, considering all that, why is it that you feel so strongly about the fact that psilocybin should not be used while on an SSRI whatsoever, and that ketamine is really a much better alternative for the tapering off period? I'm curious for that, just only to speak to the context of what's out there, because I think this is honestly one of the most important sort of talking points in the psychedelic space today, this sort of psilocybin SSRI conversation.
So I was just saying, yes, absolutely. And I think it's really important for people to understand this point, because it's commonly misunderstood, and it's something that basically prevents avoidable risk, which is the biggest problem of that is, how do we preserve patient safety? And for lots of reasons, the way that we've gotten used to pharmaceuticals being administered to the American population in a way where they're not being prescribed, and the use of them is not necessarily being monitored in a way that is maximizing patient safety. And you can see that with the opioid crisis and the benzodiazepine crisis and the SSRI crisis, for instance, right? And so there's an important statistic in clinical medicine when we're looking at interventions and their relative risk versus benefit. And ultimately, if you administer somebody who's a good patient candidate who is not taking an SSRI or other serotonergic antidepressant, and you administer the psilocybin to them, you have your number needed to kill, which is the number of patients you need to treat to have one death, is 0. It's infinite. It's not applicable, because there's no risk of death with psilocybin being used without SSRIs on board. All of a sudden, you introduce SSRIs and you look at that patient population, and there's a non-zero number needed to kill. And so when we think about, especially as physicians, we're trained, and my nonprofit medical board, the Board of Medicine, it's actually just wrote to HHS and proposed a clinical program for them to deal with the SSRI overprescription problem with this taper method, so that patient safety is prioritized as number one. And ultimately, if we understand that there is a risk of death that's relatively unpredictable with SSRIs on board when you treat somebody with psilocybin, and that goes away completely without it, with just a standard patient screening interview, then from that standpoint, you might as well just work with somebody to taper them off of their SSRI first, right? And so it's just minimizing risk. And that's the old way of practicing medicine that kept people safe, kept the American population safe over the last 20 to 30, 40 years, in large part because of the way that opioids were handled. It hasn't been that way in a lot of areas of medicine. And so we need to get back to that, because that's how we maintain trust with the medical system as a system that evolves with our society, that helps continue to make us healthy and integrate new treatments and iterate quickly. Our system is stagnant as of 25 years ago, except in certain surgical specialties. Everything else is the same, so we need to upgrade medicine and make it easy to upgrade with these tools, and safety has to be the priority, because if just a few people die accidentally from using these SSRIs, for instance, with psilocybin in particular, and I think on the last call that I talked about this last course, there was at least one person on the course who was attending. One of the attendees had this happen to them with a microdose of psilocybin with SSRIs on board. So it's not a trivial chance that this could happen. It's like 1 in 100 or 2 in 100 people who take psilocybin with an SSRI, and it's just a dose dependent thing that they're going to have an increased likelihood of getting it. So if we minimize risk, we increase the likelihood of psychedelics being approved without as many safety concerns from the federal government as well.
Oh, that makes sense. What about Wellbutrin?
Wellbutrin is like more like an amphetamine antidepressant in terms of how it works. It's like more glutamatergic. It's more speedy. And so I think that in general, for a better quality of psychedelic experience, and that's also part of it with SSRIs, like what we forget is that if you're shrinking the emotional window of awareness, and then you're putting somebody into that shrunken window with a bunch of psychedelics, like it's going to take so much more medicine for them to get to full awareness, but full awareness is capped for them here, right? So that's actually one of the big reasons why people end up when in the macrodosing world or microdosing world, they end up taking too much, because they're like, I don't feel this I remember feeling this dose. So then they take more, and then they still don't feel it because the SSRI is restricting their awareness. So that's why another reason, like you end up just wasting medicine when you're taking SSRIs at the same time, because you have to use so much more, and you still can't get to the peak effect that you would otherwise get to in a macrodosing experience. With Wellbutrin, it just decreases the effect. Amphetamines just decrease the effect. Antipsychotics decrease the effect of psychedelics. Lithium is one of the only antidepressant medicines that actually, and mood stabilizers, that actually works with ketamine in a positive way. So if you have lithium on board, you can actually administer ketamine, and ketamine's effects in a few studies have been shown to be potentiated, meaning they last longer with lithium on board. And so oftentimes I will have my patients do 5 to 10 milligrams, especially if they have mood lability as a symptom. Like when they come to me, they're not bipolar, they're not like, they don't meet criteria for manic depressive disorder, but they have a lot of like mood instability where they're bouncing up and down a lot and having trouble regulating. And so as a trick, I'll use like 5 to 10 milligrams of lithium, which is a microdose of lithium. And then that continues through their ketamine experiences, and it augments their ketamine experiences, but it does not augment experiences with other psychedelics, just ketamine.
Okay, the third and final point, right? And this is, I think, an important point. I'm mostly, I'm not doing this in a antagonistic way. It's just these are the questions that I'm seeing in the conversations.
Of course.
And I've seen this with a few even legal psilocybin facilitators in Oregon who are noticing this. I think the final point about the SSRI conversation is this sort of notion that getting someone weaning off or just going cold turkey off SSRIs so they can do psilocybin is also problematic, right? That it may cause destabilization. And so that's some folks' concern is, the SSRI can sometimes help to create stability in the midterm before someone is fully ready to wean off. So I sort of you talked about this a little bit, but just to make this very practical and easy to follow, when you're working with clients as a psychiatrist who's very well versed in traditional psychiatric medications and psychedelic medicine, how are you typically helping them to wean off SSRIs? What does that protocol for you look like? And what is the role of the nervous system in that process?
That's a great question. So it's actually a lot simpler than most people would think, but again, we're just not taught it that well. So follow with me for a minute. So basically, SSRIs, going back to what we were talking about before, shrink your window of awareness, right? So that means you don't feel as low lows, but you also aren't feeling as high highs. So that's why most people who take SSRIs stop feeling as depressed and deeply sad and anxious, but they also lose the ability to climax and orgasm, right? Because that's a peak joy state. And so that's the downside of those medicines. You lose both. And that's basically explains almost every side effect of SSRIs as well, is they come from that losing of the top and the bottom, cutting it off. So that includes the extremes of feeling in both sides of the spectrum. On the downside, the side we consider unpleasant, and the side we consider feeling good and elated and happy. And so when you remove the SSRI, the first thing that happens is people start to feel a lot more feelings. And those feelings are both oftentimes really joyful and happy, but they're also feelings that are equally as present or maybe more present, that are fearful and sad and upset and guilty and shameful. That's everything is coming back from those two ends of the spectrum that were cut off from before. And sometimes it comes back really fast, and sometimes it comes back kind of slow, but consistently over the course of your days of taper. And it definitely stays because it's not something that wasn't there. It's just your awareness, the brakes on your awareness that were keeping it here have been taken away. So that means your awareness now is like all of a sudden nearly instantly fully expanded over the course of, it's not instant. It's like, it takes 4 weeks-ish for the serotonin SSRI to leave your system completely. So over the course of that 4 weeks from the moment you stop taking your SSRI, your awareness is expanding a little bit more every day to get back to that full spectrum. And that can be really scary for people because that's a lot of feeling that wasn't there before. And they may not have learned the psychotherapy techniques that their doctor was supposed to be teaching them to understand how to cope with and adapt to that sudden increase in feelings again that comes from when we stop your medicine. That's the way we used to do it, is help the drug is the bridge to the psychotherapy that stabilize people enough to do the psychotherapy, to learn the emotional regulation techniques, and then you remove the drug and they are good. But so if we understand what happens to people when the medicine brakes are removed from awareness, you understand also that overwhelming feeling can cause feelings of fear, lack of safety, heart rate goes up, blood pressure goes up, respiratory rate goes up, people start sweating, they start having like racing thoughts, like anxiety, significant anxiety. And that puts the body into a state of resistance and threat, like fight or flight. So all of the tools that we use are tools that help to soothe the body into a state which is basically a state of slightly heightened vagal nerve activation, which governs the entire recovery nervous system of the body from the brainstem. And by doing different techniques, which include everything from the deep breathing, meditation, mindfulness, yoga, soothing touch, soothing music, eye-to-eye contact, touch therapy, and things like Apollo. And combining all of these different vagal nerve techniques, that sends a huge amount of soothing stimulation to the nervous system. And then your awareness is widening, so you're still getting you're still noticing more on both sides of the spectrum, and it's still challenging, but your body feels safe when it's going through it. It's not triggered into a fight or flight survival response. And when your body feels safe, then you're reminded that you can get through it, and then you get through it faster. And then, but biochemically speaking, it does take 4 weeks for the SSRI to completely leave your system. So that's the protocol they use in the MAP studies, for instance, is they had at least 4 weeks of taper of no SSRI on board in the system before they administered MDMA to ensure that there were no side effects. So it's real, and I think like the main thing is like, luckily we have other tools. Like I think that psilocybin microdosing is actually much less effective while you're still taking your SSRI because they are opposing each other in mechanism. And so if you take the time to work with your natural tools or with Apollo or with ketamine and a seasoned provider, even in one dose of ketamine, you can taper off of your SSRIs and be like good and not have withdrawals. I've seen it happen. You know what I mean? So it's like, it's not a huge amount of work, but it's like a solid 1 to 4 weeks of effectively preparation for your microdosing course that hones your intention to maximize what you get out of the microdosing experience in terms of breaking old habits and learning new ones. Does that make sense?
Totally. Yeah, I'm tracking and following everything and all the comments. And I do want to spend a little bit more time talking about psilocybin specifically. So let's let's assume there's a process that an individual can follow where they utilize ketamine to get off SSRIs, right? They've been clean of SSRIs for about 4 weeks. If someone wants to start to do, let's say, therapeutic work with psilocybin, they're interested in higher dose work, they're interested in potentially microdosing, how might that previous relationship with SSRIs impact their sensitivity, impact their dosage, impact, their sort of normal capacity in that space? There's a few questions around that. In other words, Dave, maybe another way to ask the question: if someone's been on SSRIs for 30 years, are they actually going to be able to feel anything, even if they've been off their SSRIs for a month? And how does that compare to someone who's just been on SSRIs for a year and they're weaning off now, and now they're trying to get into work with psychedelics or psilocybin?
We don't know for sure the difference between somebody who's been taking them for 30 years versus 1 year. We haven't done those really long-term studies, or a lot of them are still in progress. But I
do you have speculation that you could share in terms of maybe what you've seen in clinical practice, or kind of?
What the data that we do have would suggest is that the longer you're on the SSRI, the longer you have spent in kind of like an awareness constricted state with less feeling. But the thing is, when you when you take the medicine away, when you remove it or taper it slowly, people do generally nearly every time have this pretty profound expansion of awareness. I haven't seen a significant difference in my patients between people who have been taking it for 30 years versus 10 years. And sometimes the 30-year people actually respond to the psychedelics more because they haven't felt in so long that their sensitivity to it has heightened dramatically. And they have like quick breakthrough psychedelic experiences where, like, I have a woman right now who actually had a very, very unpleasant psilocybin macrodose experience shortly after tapering off of wasn't It was not related to the SSRI that she had the bad experience. It was because she wasn't prepared properly for the experience, and the guides, who seemed fine, were not prepared to hold somebody who had such severe childhood trauma and had such severe depression and addiction issues that she was like she needed a lot of support and help, and they just didn't know how to prepare her for what she was going to face or to hold her in that space. And so she had a very hard time. And so she came to me afterwards, and we started doing ketamine work together. And again, this woman had been taking SSRIs for decades. And she had tried ketamine before. She had tried sometimes without without her SSRI on board. And then she stopped the SSRI 2 weeks before she did her psilocybin experience, and then restarted it because she felt so bad after the experience that she needed something. So we did ketamine with her and have tapered her off of her SSRI. And 1 dose of ketamine was all it took for her. Like, I would have thought it would have taken 6 going into it for sure. 1 dose with the practices that we do in our clinic, which are about, basically all the brain rewiring practices that I teach about, and attention training and all these things, like with some cognitive behavioral therapy and some IFS thrown in there, right? And you get in motivational interviewing, and you get this like really nice window of change where people can, like, all of a sudden, by feeling just a little bit more safe to feel their feelings, they're able to understand what those feelings are telling them, and then their feelings are telling them what to do to feel better. Like, think about how simple that is. Like, it blows your mind when you think about how simple that is in terms of like the path to healing. It's feeling safe enough to feel your feelings for even just a little bit of time, like 60 seconds, so that you can understand what the feelings are signaling or telling us, so that we can do what we need to do to allow that feeling to like get out of our bodies, basically, to like move through us. And then we move on to the next thing, but we have to feel safe enough to feel it. So so I think like the duration of the SSRI use, I don't think doesn't really matter that much. I would say, like, if you have 4 weeks off of your SSRI, you're going to be golden for your psychedelic experience. I'm not concerned at all about people's response. What does decrease response in addition to that is if they have like really intense anxiety when the SSRI has stopped, and that their anxiety is like unmanageable levels of anxiety, like generalized anxiety disorder, high levels of anxiety. That will shut down almost any psychedelic experience. I've seen that shut down everything, like LSD, MDMA, ayahuasca, ketamine, all of it. If you have anxiety at that level, then that person's probably not ready for a psychedelic experience. They probably should be, more slowly tapered or trained more in psychotherapy techniques to help them manage.
So we have some great questions coming in, including from John. But we have about 5 minutes. So Dave, if I can get 2 more questions in, this first question and then another one would be good as well. Talk to us about strains of mushrooms and how those may differ in terms of the experience. We were talking about this a little bit before we went live, and you mentioned penis envy, for example, versus golden teachers. Like, talk to us a little bit about what you're noticing from a strain perspective and the impact that it may have on anxiety and sort of the experience of microdosing with psilocybin.
Sure. So there are many different strains of mushrooms, like probably as many as there are strains of cannabis. There are so many strains, thousands of strains, and each one of them has different plant alkaloids and other bioactive molecules in them in the hundreds. And they don't just have psilocybin. They have hundreds of other plant molecules that change the way that psilocybin affects our bodies. And so different mushroom strains have not only different percentages of psilocybin, they also have different experiences that come along with them. And so there are certain mushrooms like penis envy mushrooms, which we talk about a lot, and we see a lot because they are some of the cheapest, biggest mushrooms to grow that are very dense in high levels of psilocybin. And so a lot of people who really like to give out sell stronger medicine and use stronger medicine will gravitate towards those, but those became the most common strains that are around in chocolates and other microdosing tinctures. So it's important to find out, if you can, what mushrooms are in there. If they're not labeled at all, they're usually penis envy mushrooms. Penis envy mushrooms increase rumination and increase your self-critic and increase your self-referential analysis of yourself, which is fantastic if you're in like a deep in a psychotherapy session with a trained provider, or ideally 2, but not exciting at all when you're at work or interacting with your family or at home alone or doing other things that driving a car, right? Like, not good for any of those other kinds of situations, not good for microdosing for most people. Some people who are very tolerant of psychedelics, many will microdose with penis envy, but especially for people who have anxiety and anybody who is new to microdosing, that's the last one that I recommend, along with the blue azurensins and some of the other blue and stronger mushroom varietals. I will just stay away from those for
golden teachers. I find are really the
golden teachers are a very reasonable place to start, like middle of the road, and they're of medium strength. So they're not super. They're like kind of gentle in the experience. But there are now even better strains that we can use that if you have the ability to get them or grow them, then you can, Maui Platinum is a very, very good gentle strain. It's very like chill and not anxiety driven at all for most people. And then Mexican style mushrooms, the Mexican strains of mushrooms also tend to be slightly lower psilocybin levels, slightly more gentle than golden teacher, and just easier for people to tolerate. And so we always like to start there if we can, because it just helps people have a better first experience, and they are motivated to come back and do it again with have different experiences.
All right, Dave, final question, then we're going to open it up for some Q&A before we have Ali. Final question is, you're a psychiatrist, you're a psychedelic practitioner, you've been a faculty in our 10-month certification program since the get-go. Dave and I, by the way, are co-producing a course that we will come out with around psychedelic safety and nervous system regulation. So we'll have more details about that in the fall, but I just want to peek that. What is your toolkit when you're working with clients who are on, just to sort of recap all of this, when you're working with clients, they come on, they're on SSRIs, they want to get off SSRIs, you want to make sure you can support them to the best of your ability and their ability. What toolkit are you bringing into those conversations? If you could just sort of like run through that list for us. What are the sort of the most essential items that you're ensuring are brought into that?
I mean, do you want me to start with like the supplements and things I use of that variety, or are you more interested in like the psychotherapy techniques?
Everything. If you had a top 5, because I am being mindful of time, we don't have too much, but if you could sort of summarize in 1 to 2 minutes, what is that optimal toolkit for you? What would that be?
So I'll give you a few of them right now. So one of them in terms of supplements is the CBDA tincture that is absolutely stunning. And it's the best, it's best in its class. It's CBDA, it's not CBD. So it's really, really hard to get because it's effectively the cold pressed extra virgin olive oil organic version of CBD. And it's thought to be 30 to 50 times more potent than standard CBD, which is heated when it's produced, where CBDA is cold extracted. So it's most cannabinoids are actually more anti-inflammatory and healing in the anti-inflammatory end of the spectrum when they're not heated, which is not something that many people out of California has been passed on. So that's the main supplement that I would recommend. In addition to Paul Stamets, the immune complex mushrooms that are like 21 different mushrooms. I think it's called like the immune complex, which has specific mushrooms that increase cognition, learning, neuroplasticity, and work well with psychedelic medicines, including ketamine and psychedelic mushrooms. And then the last tool that I use is Apollo as a primary tool, which everyone starts with when they first start working with me. And Apollo is a wearable and a app on your phone, if you have an iPhone, that can basically deliver soothing vibrations to your body that regulate your vagus nerve and help improve the functioning of your nervous system, and affect as if you were meditating or deep breathing, but sound wave assisted. And you could wear it, or you could try it if you go to thehugvibe.com in your iPhone. You can try it on for free. Free trial only exists for iPhone, unfortunately, but the wearable works with Android and iOS. And then I think the last couple quick things are on like the way that once people have the tools in their toolbox, they know they're not alone just figuring this out on their own. With those 3 tools I just mentioned, then people have something that they're taking regularly for adaptogenic boosting, anti-inflammatory boosting, and cognition. So that's the CBDA and adaptogenic mushrooms do those 3 things. And then they have the Apollo for regular mood stabilization, as use, recovery, enhancement, and sleep enhancement, etc. But also, importantly, as needed relief. If you're feeling distressed, if you're feeling like you're stuck in like a really tough place, you can just go and use that anytime, and it trains you how to self-regulate in stressful situations, and it has no side effects. So that's the toolbox that we can arm people with, including some playlists also, which are like, people understand the impact of music in this way. Then there's the way you talk to people, which has to be genuine eye-to-eye contact, actually connecting with people in a natural way that shows that you're listening to them without judging them. And that's really all we're communicating, is non-judgmental listening. And one of the first things that once we communicate that as the core focus of the interaction that starts to build trust with our clients, we focus on a series of 3 primary therapy types. We do some other stuff in there too, but the main one to focus on first is motivational interviewing, because motivational interviewing is brief interventions that are 10 to 15 minutes or 5 to 15 minutes long that help us as clinicians understand what somebody's motivators and drives are and what motivates them to do the things that they do in a non-judgmental way, of course. And then once they have shared that with us, then we can, by understanding their motivations, help them start to motivate them to ask questions like, how do I do it differently? What options do I have? Like, can you teach me about how different healing techniques work. And then you're like, oh, well, would you like to know about CBT? And they're like, could that help me? And you're like, yeah, there's actually a lot of evidence to show that it can. And here's a technique that we use. And then we offer some core cognitive behavioral therapy techniques when they ask for it. But when they ask for it, they're much more likely to actually do it. So we don't want to offer it to them before they ask. So it's like a very, thoughtful, like meet them where they are approach, which does not take a ton of training, which is actually the beauty of it. We're releasing a manual to teach people how to do this work soon, but from our clinic. But that's the gist, is just like connecting with people in this way that they're heard and seen and don't feel judged and feel held. And then they'll tell you what they need to do to feel better, because they know like way better than we know. We just are kind of like a guide to help them hear themselves, figure it out for themselves, and kind of like hold their hand and guide them to the answer. So that's really helpful when that foundation of trust carries over into every part of your clinical experience. And when you experience that, the administration of medicine afterwards as part of that experience, you will see that the outcomes with your clients will be much better and longer lasting, because it's built on the foundation of trust that we have built with them. And then of course there's like IFS and some psychodynamic, Freudian stuff comes out in there too along the way. But, we don't force that on people. We like let them kind of ask for the support that they need through their insight into their motivation.
I love it. All right, let's get into questions, Dave. So first question is from David. If most SSRIs take 4+ weeks to be therapeutic, how long does psilocybin or microdoses of psilocybin take to actually work? So let's say someone is ongoing low-level depression, has never been on SSRIs. What is the protocol you would recommend? And I would share more on this, but I'm about to cough. So take it away.
Most SSRIs are most antidepressants, whether you're looking at like psychedelic like antidepressants, like of which ketamine is, and you could call psilocybin, and also other antidepressants that preceded SSRIs like tricyclic antidepressants and MAOIs. They all work or start working almost instantaneously. Like as soon as you've digested and metabolized the medicine, it could start to have a noticeable effect for you. Whereas SSRIs don't, because they work by inducing a long-term delayed reuptake response in the receptor, where that's reuptaking the part of the cell that's reuptaking serotonin. Their mechanism actually takes much longer, but it's relatively unique to SSRIs that you have that like 4 to 12 week window where the full effects are not necessarily achieved yet. So most other drugs that we use work nearly immediately. And I don't know, what was the protocol that you wanted?
But I think just because I want to keep moving because we have a few more questions. I think the sort of standard protocol of what I would call the Paul Stamets protocol, 4 days on, 3 days off, or the Jim Fadiman protocol, 1 day on, 2 days off. And I've seen folks who start to experience an uplift in like 1 to 2 weeks, or sometimes even with the first dose. It just depends on how it's done. And
I would say, and for that, I'm more a fan of, for people, the kind of folks we're talking about who are like new to psychedelics, who haven't had a lot of experience. I think the Fadiman protocol is actually the best way to start. It's more gentle, gives you more frequent time for introspection. And then I think like the Stamets protocol is more like an advanced microdosing protocol, is kind of how I look at it, when you already have some experience doing it. But I would say you're right. I mean, it's probably like you shouldn't notice the effect in 1 day with microdosing. It's supposed to be a sub-threshold effect where you don't really notice much when you're microdosing as dose guidance is concerned. So you really should, I would say, like you said, it's similar in that way. And then it's probably 2 to 4 weeks before most people notice like their mood is substantially different, or they're ruminating a lot less, or they're having like a lot less negative intrusive thoughts, or things like that, more energy. I would say it's usually 2 to 4 weeks.
Okay, final question, 60-second response. Then I got to bring Allie up to do her thing. Do you believe microdosing psilocybin is going to be sort of an upgraded SSRI, or do you believe that these low doses of psilocybin actually offer a totally new paradigm of care?
I think low dose psilocybin is going to be, and drugs like it are going to be the next generation of antidepressant medications that's going to be mainstreamed, right? And it's going to be dosed like antidepressants are dosed. It's going to be not every day maybe, but it's going to be dosed like every third day for a really long time. And hopefully there are therapy protocols that are encouraged along with it, but we know that those are not always upheld. But I think that the macrodosing is really where the paradigm shift happens, because in the macrodose experiences, you're really like, you have ego death opportunities and opportunities to really like dramatically shift consciousness in a single 8-hour period. You can shift how somebody sees themselves as a human being and what being alive means to them, right? And that's not something that typically happens or should not be happening in your daily microdose experiences or your weekly experiences. So I think like that's where that matters more. But I think microdosing will, in fact, like the data is showing that like it needs to be looked at as a very affordable, very successful way to start to manage depression more effectively than what we're currently doing. And it has a ton of promise, and we just need to not accidentally hurt ourselves along the way.
I love that. Dave Rabin, it's been an honor. Thank you so much for joining us. For those of you who are coming for the first time today, thank you. I see a lot of familiar faces here, so we really appreciate you showing up and asking all these great questions. It's been fun. We'll see you next time, folks.
Thanks so much for watching. For a deeper dive into the power of microdosing with complimentary practice and extra guidance, check out our best-selling microdosing course. It's a science-based protocol with dozens of best practices so you can customize your protocol to your unique needs and goals. Check out the link in the description below.